Hello, this is John Rosenberg. Welcome back to the NCS podcast. We're coming to you from Westchester Medical Center. I'm joined with Dr. Stephan and Dr. Krishna Rajajee.
How you doing, Krishna?
So,
Hey guys, how are you?
so
We're good. Good to see you. This is the master class, and we're going to be talking today about non-invasive intracranial pressure monitoring. We have an expert here who's funded research, has focused on non-invasive ICP monitoring, and today we're going to pick your brain.
sure. Just for our listeners who maybe haven't heard of you already, Dr. Rajajee is a neurointensivist and vascular neurologist, professor of neurology and neurosurgery at Michigan, where he serves as the medical director of the neurocritical care and co-director of their comprehensive stroke center. Dr. Rajajee is a pioneer in critical care ultrasound and non-invasive ICP monitoring. He's also the former chair of the NCS Guidelines Committee. I encourage all the listeners to review his article, Non-invasive intracranial pressure monitoring, Are We There Yet?, published in Neurocritical Care last month, in addition to his prior NCS podcast on optic nerve sheath diameter and the NCS Guideline Review. Dr. Rajajee, welcome back to the podcast. I hope the intro does you justice, and I think it's fair to say you're a friend of the show now.
I am. Yeah, no, it's been great being on the podcast. Thank you so much for having me back, John.
Sure. So let's get into it. Let's talk a little bit about non-invasive intracranial pressure monitoring. I think we have TCDs, pupillometry, optic nerve sheath diameter. Maybe let's start with one of those, and we can review all three and tell us a little bit about your thoughts on them and how you use them in practice.
Sure. So, I think maybe start with optic nerve sheath diameter then.
Perfect.
Yeah. Among the various non-invasive means that we use to measure intracranial pressure, I think optic nerve sheath diameter measurement is probably the best studied, arguably the best studied, sort of originates from the concept of papilledema. So, some people like to refer to it as papilledema 2.0. And a lot of the early work was done using autopsy specimens by Helmke and Hansen in Germany, where they basically infused fluid into the subarachnoid space, within the optic nerve sheath, and demonstrated that when you simulate an increase in ICP, the optic nerve sheath distends as you would expect it to, and that you can measure that using ultrasound. So, eventually that's followed by a bunch of human studies where you perform an ultrasound of the eyeball. You measure the diameter of the optic nerve sheath at a specific point, at a fixed point behind the eye, because depending on how far back behind the eye you measure it, you're going to get very different measurements. So you use the same point, same distance each time, and you measure the optic nerve sheath diameter, and then correlate it to simultaneous invasive intracranial pressure monitoring. And so, there's been a little bit of a saga with ONSD measurement. I don't think the story is ended yet, but I think that with a lot of other critical care ultrasound tools, the early spate of studies were very positive. We did one of those studies, and we saw pretty good correlation with invasive ICP. I have since transitioned to being a little bit more of a skeptic, and I think gone from being one of the proponents to being a little bit more skeptical about at least clinical use. It's not like there hasn't been sufficient time to evaluate this tool. There has. We've spent well over a decade now studying this tool, and at least based on some of the work that we've done, where we attempted to address some of the sources of bias in these studies. Bias in these studies is a big problem. So addressing them, I think, is really important. I think in at least one of our studies where we tried to address bias, the results were not nearly as good as we had hoped. And I can talk more about the reasons that I think that we should be careful about using this day to day in clinical practice. But I think that I think the bottom line is there's clearly a biological relationship, as you would expect. Just as with papilledema, there's clearly a biological relationship between high ICP and optic nerve sheath distension. But in terms of being able to use it at the bedside in the ICU to decide when to initiate treatment of ICP, when to not initiate treatment of elevated ICP, that I think is more problematic.
Let me ask a question. And what about using it in your clinical practice to help you decide when to put a bolt in? Your review article starts with a scenario of a fulminant hepatic failure patient and an elevated INR. Um, you can reverse the anticoagulation and put it in. There's still some residual risk that's probably higher than a non-coagulopathic patient. But do you ever do that to select patients for invasive monitoring?
So we've never used, so just to give you the background on that, Stefan. So the University of Michigan, we have a long-standing protocol for invasive monitoring in patients with acute liver failure. We put the protocol in place around 2011, and we've had over a decade of using that protocol. The fact that we regularly did invasive monitoring these patients allowed us to then study non-invasive techniques, more accurately. So there were several years in which we simultaneously performed ONSD measurement, transcranial Doppler, along with ICP measurement, and then correlated against the gold standard. ONSD did not perform so well. So we published our experience with invasive monitoring after our first 5 years of using the protocol. We followed that up with another publication in New York Critical Care, where we compared our non-invasive experience, measurements with against the gold standard of invasive. ONSD really didn't do well at all, to the extent that I would not use it. We also looked at transcranial Doppler in this context, and transcranial Doppler did better. I mean, it's by no means a perfect tool. It's an extremely flawed tool, but it actually did better than optic nerve sheath diameter in our liver failure patients. So, I mean, so to answer your question, I wouldn't, I think I would use other tools to select patients for invasive monitoring if you were going to do it at all. I'm happy to discuss sort of an approach to your approach versus, our approach to acute liver failure, because we all know there's no one, perfect approach to these patients. But I would not use ONSD to select patients. I think sort of is what we've come to over the years.
And it seems like for our listeners, one of the reasons, and correct me if I'm wrong, some of the reasons are one, the interrelated reliability seems to be quite poor unless you have follow-up training. So different examiners, we see in real world with different examiners doing it, you can get widely different measurements in the same, on the same patient, and then different studies have shown different cutoffs. So depending on what you pick as your cutoff, if you want distension greater than 5 millimeters, 5.5, 7, you may have a different sensitivity, specificity, and that those sensitivities and specificities actually haven't borne out to be the same at different cutoffs.
Absolutely. Yeah, no, you hit the nail on the head. I mean, those are very much the two issues. I think that if you've got people who are experienced with the measurement of ONSD, just taking a step back, there's actually a debate about, how best to measure ONSD at all among experts. But let's assume that you all agree on one way to do it, and then you are experienced in doing it in that way, and you teach others, and they do it the same way. Over time, you can get very good inter-rater reliability. But that's not the reality of clinical practice. The reality of clinical practice is that, a person at the bedside doing this is often not experienced. They're often fellows, residents, and maybe they've done it a few times. Maybe you've shown it to them a few times. And then the inter-rater reliability really may not be as good as you think it is. I mean, that's what we found in our study, where we went through this process of training, folks at the bedside, the providers at the bedside, to do this. We had to check them off. So we had the experienced people, have them do 20 studies and then check them off. But then after we did 50 studies, we saw that there was very poor correlation between expert measurements and inexperienced folks. So we went back and trained all of these folks again, and then you had really good correlation. But you got to be very cognizant of the fact that just because you train people to do this, it doesn't necessarily mean that they're going to do it exactly like you would want them to. And this is certainly not unique to optic nerve sheath diameter measurement. We've seen this exact same thing with other forms of critical care ultrasound.
Why don't we jump to TCDs? Maybe we could talk a little bit about your experience with TCDs, the literature behind them, and how you use them in clinical practice for this
Sure. So,
ICP.
yep. So transcranial Doppler for, elevated intracranial pressure. So, I mean, I think sort of the thing to start with is that there's no single way to do this. We focus on the Sosnica technique, but there's actually many different ways that you can use transcranial Doppler to assess ICP, ranging from relatively simple, like a pulsatility index, to extremely complicated. But I think that the best evaluated way to do this is using the Sosnica technique. Marek Sosnica developed this technique at Cambridge back in the late 90s. And essentially what you do is you measure flow velocities in the middle cerebral arteries. You simultaneously measure the mean arterial pressure from an arterial catheter, and you use a formula that he developed to estimate the cerebral perfusion pressure. Obviously you know the mean arterial pressure, and so you calculate the intracranial pressure. So over the years, that's been best evaluated. To my knowledge, it's one of the few tools that's been evaluated in a pretty, high quality study, I would say. It's an international multi-center prospective study. It was impressive too. And so, that's really what we use. That's what we've evaluated in all our studies, liver failure and in sort of general neurocritical care populations. The thing about TCD is it's harder to do really than optic nerve sheath diameter in some ways. You really probably should be certified in TCD. You probably should be able to do it well. And then there's a bunch of technical considerations. For example, our recent study suggested that you should perform angle correction, which you can only do if you've got duplex transcranial color-coded sonography. If you've got a regular TCD machine, you probably can't do that. I think there's the where you level the transducer, whether you do it at the phlebostatic axis or the tragus, has probably a pretty significant impact. So there are all these technical considerations. Now, if you're able to do it, then I think our experience is that it's like a lot of other non-invasive tools. It's probably best used as a rule-out tool. In that if it looks entirely normal, if your calculated ICP is normal, it's not perfect, but there's a decent chance that the ICP is actually normal. If your calculated ICP using the technique that we do, and I just want to be very particular about that, using the technique we do, which is leveling to the tragus, performing angle correction, using technique we do, if the calculated ICP is elevated, really doesn't mean that much, unless it's extremely elevated. And so in that case, you just need to look at your other modalities, maybe papillometry, maybe something else, and just do serial measurements to see where things are at.
So,
Krishna, why don't you also look at the straight up pulsatility index at the same time? And you've got a Doppler probe there. Is there any way to integrate the two techniques to maybe improve the sensitivity?
Yeah. So to answer the first question, Stephan, yes, you can look at the pulsatility index. Our study and other studies, I think, suggest that it's not as robust a tool as calculating the ICP, but it's much easier to do. For sure, it doesn't require someone who sort of knows the specific technique. You can get a tech to perform the TCD, and you just get a pulsatility index. So pulsatility index that is entirely normal, that is less than I would say 0.8, is relatively reassuring. It's not entirely reassuring though. So whatever TCD technique that you use, I think the thing to understand is if you just look at all of the diagnostic accuracy studies, all of these studies have a pretty large confidence interval. None of these studies really have enough patients to have a tight confidence interval. So there's a pretty significant room for error. And if you look at the best study of this technique, which is impressive too, then they focus on the negative predictive value, which is 96%. But the negative predictive value is not necessarily the right number to look at. It's probably the sensitivity that you want to look at. And the sensitivity is really not that good. It's maybe, I think, in the 80s. So you can use it whether you're using the estimated ICP or the pulsatility index, you can use it. You can get some relative reassurance from a normal value, but I wouldn't run with any one modality alone. So that leads to the second part of your question: what if you integrated it with other numbers? I think that's basically what we do. If the PI is entirely normal, the estimated ICP is probably going to be close to normal because the principle is large, similar. Um, but I would not integrate it with another TCD modality. I would integrate it with entirely different modalities, whether it's pupillometry or a CT scan, whatever else you have, to be honest. Because, one thing I think we have learned is if you rely excessively on one tool or one measurement, that can really lead you, wrong.
Hmm.
If I can summarize what you just said as well, there was a lot of high level critical care and ultrasound just described in that SNP. But basically, what you're saying, so TCDs in the most validated form, which is the formula with Chosnica with continuous TCDs and a formula to measure CPP based on your flow velocities. That's been the most validated. In doing that, you found one, you actually in the Impressa trial and in what most of the literature has shown is that the strength of that, even in our best modality, is the negative predictive value. That there's a high negative predictive value, but the positive predictive value for elevated for TCDs and the sensitivity is not great, which makes it difficult to be solely to rely on it as a screening test. The other point that you make is that TCD. So when you Doppler ultrasonography is very angle dependent. So if you're intonating the velocity of the MCA and you don't have the correct angle, your angle's off by over 20 degrees, then your flow velocity may be off. So it's very, again, operator dependent, and that you may be underestimating your true flow velocity. The other interesting point is it sounds like for when you do TCDs, you level the art line at the tragus as opposed to the phlebostatic axis. Did I catch that?
So we level at the phlebostatic axis, to be honest. So we level at the phlebostatic axis. The reason we do that is that's been the culture at our ICU going back a very long time. It's very difficult to change that. So even when you conduct research, it's just, it's too much to try to, tell people to change the transducer level. Maybe we should, but we just found it more convenient, I guess, to go with the standard clinical practice on our unit. Impressa 2, though, they did level to the tragus. Impressa 2 is an international multi-center prospective study. So if you want to go with the best validated technique, it's probably their technique, and they leveled to the tragus.
But and that also points to the overall, one of the issues with non-invasive monitoring is if you're going to use the technique in the Chosnica formula, if you don't level the A line at the tragus, then your numbers aren't going to be, your cutoffs aren't going to be the same. Your sensitivity, specificity for that cutoff won't be the same.
Yeah, I think you just have to understand the impact of where you level, because my understanding is that Chosnica actually leveled to the phlebostatic axis as we do. Impressa 2, they level to the tragus. So it's more a question of understanding what the implications are. So what we've seen, for example, is that if you level to the phlebostatic axis, you see what we saw in our study, which is a consistent overestimation of ICP. So you just have to understand that if you do it using our technique, you probably will overestimate ICP. If you level to the tragus, from what my experience is, it's closer to the actual ICP, but then your sensitivity is actually lower. So yeah.
If I just want to, for our listeners, this is a very high level conversation, and a lot of our listeners are learners. So just for point of clarification, I'm going to share my views about this whole leveling your ICP. This may sound like an obscure discussion about, non-invasive ICP using transcranial Doppler with a mathematical formula that, Sonika developed. This is a day-to-day issue, and every nurse you around the world every day when you transduce ICP off a ventricular drain, right? Where do you level that pressure transducer? And my understanding of the conventional wisdom is the true ICP is going to be measured in the case where you have the pressure transducer at the level of the tragus, which approximates the foramen of Monroe. And that's really important when you're head up, which many of our patients are. However, if you go head flat and you feel the patient can tolerate that, the level of the ear or tragus is at the level of the mid-axillary line, and it's kind of a non-issue. So I'll just, at this point, I'd like to ask you, Krish, to move over now to your views on pupillometry. Can you explain the rationale? Why would measuring a pupil tell us about ICP?
Stephan, can I squeeze in one more question before we do?
Sure.
Quick. So, most of the setups in the ICUs, we do intermittent TCDs. A tech comes around, does TCDs. Is this enough to get to use the Chesnica formula, or do you really need continuous TCDs?
Well, so it's what Chesnica did was not just continuous TCD, it was digital waveform integration, with the waveforms from the monitor. So if you could do that with your intermittent TCD, I think that would be great. I don't think it's really about continuous TCD as much as that integration of waveforms. So if you were to just stand there doing your intermittent TCD for, I don't know, 10 minutes, 5 to 10 minutes, and then you have a system by which you can do a digital integration of waveforms. It's not that complicated, right? I mean, many of us do the PRX or something similar every day. If we had a tool like that, I think that would probably be technologically superior and probably better. But that's not the reality of what most of us have, available to us. So most of us will probably continue to do just this intermittent TCD and then look at the screen and see what the mean arterial pressure is and have somebody note it down.
Okay. Why don't we move on to pupillometry now? Tell us a little bit about the literature on pupillometry and how you're using it.
So I think some of this discussion, like you guys have said, has been a little technical, a little high level so far. Pupillometry is probably the most intuitive. I think for most of us, it's nature's ICP monitor, right? And so it's honestly, you ask me, I think that's its great strength, that it is easy to do and it's intuitive. We know that when your ICP is elevated, particularly when you're on the brink of cerebral herniation, then there's an impact on the parasympathetic tone transmitted through the third nerve, through the oculomotor nerve, and that's reflected in pupillary dilatation initially, right? Because your pupillary fibers are on the outside. So that goes first, and then eventually you get a complete third nerve palsy. And it's just that very simple principle that elevated ICP is going to impact your oculomotor nerve and therefore your pupils. It's the oldest principle in neurocritical care. I think where pupillometry takes this a step further is that when you do this manually, it seems like none of us do it very well. All of the data suggests that there's a high rate of error when you manually estimate, sluggish pupils, even when you try to estimate pupillary size, non-reactivity, just even complete non-reactivity, there's just a high rate of error. There's, several studies that have demonstrated that. Whereas pupillometry allows us to accurately quantify the pupillary light response. And I think that's really where the value comes in. It's so if you have sluggish pupils, if you have non-reactive pupils, in the right context, you want to worry about elevated ICP. There's additional value in that, we know there's all these patients with temporal lobe hematomas. Maybe it's a big temporal lobe contusion, a traumatic brain injury. Maybe it's someone with a malignant MCA stroke. Maybe it's a spontaneous intracerebral hemorrhage. But all of these patients might suffer uncal herniation because they have predominantly temporal lobe pathology, even when their ICP is not particularly elevated. And with a pupillometer, you would be able to detect that sooner. So I think the use of pupillometry to quantify the pupillary light response is very intuitive. There's companies that have made it easy for us by creating these proprietary indices. The indices integrate, starting pupil size, the extent to the final size after constriction, the speed of constriction, speed of relaxation, and then create these indices, which you can use to decide if your pupil is sluggish or normal. When you use this, I think to decide if your ICP is elevated or not, I think that while I'm certainly a fan, given how intuitive it is, it's important to note that data is actually not as robust. It's just not being validated to nearly the same extent as even TCD or optic nerve sheath diameter. And so you just got to be careful about that. And when you do study it, it often turns out to be a little bit less accurate overall than, for example, TCD. So you just got to be careful. It's so easy and convenient to use that I use it all the time. But this is yet another modality that I would just, I would not take that to the bank in itself. I certainly would recognize that, if you have a sluggish pupil, again, you want to take that seriously. You want to evaluate that aggressively. But you should also recognize that when you don't have a sluggish pupil, your ICP could be elevated beyond a level that you would normally be treating it.
Yeah, just if I can share my views, I like to say once you start doing pupillometry, there's no going back. But I view pupillary symmetries and abnormalities as more of an indication of brain stem distress from displacement and torsion, which is a natural consequence when ICP is both elevated and compartmentalized, right? And that's exactly what you're going to get with transtentorial herniation or subfalcine herniation. So it's kind of for me anyway, a downstream sign that, as long as there's some intracranial mass effect at the start of that picture, that the ICP is doing bad things to the most precious real estate of the brain.
So let's say we have about, we're almost out of time, but to wrap up, how do you, maybe Dr. Rajajee, you can tell us a little bit, we'll give you a case, an acute liver failure patient comes in. Walk us through a little bit about how you want to manage that patient. Are you still sticking to non-invasive ICP, or are you doing invasive ICP?
Sure. Yeah. No, I think just with a hypothetical liver failure patient, I think our approach is predominantly non-invasive. We use pupillometry, performed every 2 hours, typically by bedside nursing, and then transcranial Doppler assessments of, estimated ICP about every day, once or twice a day. If these are normal, that's reassuring. And then, we just continue to observe the patient. If the pupillometry in particular suggests a sluggish or non-reactive pupil, that sets up alarm bells. We typically get an urgent CT and, more often than not, initiate osmotherapy or other measures to control ICP. When your TCD or pupillometry is mildly abnormal, we just continue to observe the patient. In the specific setting of liver failure, I think what is most important is, make a decision about transplant quickly. And then if you made a decision that that person should be transplanted, get on it right away. I think sitting on the patient is, what sets up the patient for something bad to happen. So I think just speeding up the process, if you've decided to go ahead and transplant, is probably the most important thing.
Great. So that's it for today. Thank you so much again, Dr. Rajajee, for participating in this NCS podcast master class.
Thank you so much, Krishna. You're welcome back anytime.
Thank you so much, John. Thanks, Stephan.
Take care.